going to be talking about emerging trends in e-micromobility with focus on safety, but also on usage patterns and the different kinds of vehicles that are proliferating on our streets right now. So a lot of opportunity with this new mode, and also some safety concerns that we have to be following closely. So we're going to start out with I'm going to introduce each speaker before we start, just to give their bio. So up next we have Connor Clark, who's the senior transportation planner at New York City Department of City Planning. So he's been there for 10 years working on projects on micromobility, bike planning, parking policy, neighborhood transportation planning, and transportation data analysis. Native of New York City. And looks like you're, I can see your screen. You want to go to full screen?
Okay, how's that look?
Perfect.
Great.
Go ahead, Connor.
All right, let me just arrange this here. Great. So I'm just going to talk about a couple of years of research that city planning did starting in the spring of 2020 about micromobility, trying to sort of see what's out there, and that we went with, which is somewhat of an industry standard, I think, is that micromobility is small, lightweight modes that run on electric batteries at low speeds. And there are sort of three kind of elements to this definition that are important for various reasons listed below. Small and lightweight means that they're sort of generally good at reducing congestion, run on electric batteries, obviously good for lowering emissions, and run at low speeds, generally safer than other modes. What we included in our understanding of micromobility was e-bikes, e-scooters, electric cargo bikes and cargo attachments, and other standing electric modes. I'll get into what that means a bit later, but Anne-Marie touched on some of those as well. And then low-speed electric mopeds, again, Anne-Marie touched on that too. There's going to be a bit of overlap with Anne-Marie's presentation, but I think it's helpful because the city is, I think, still working on sort of a regulatory framework for this. And our research revealed certain things, and I think DOT's research revealed other things, but I think there's kind of a meeting of those two. So the background to this is just that there's been a dramatic rise in micromobility use in recent years, especially after the pandemic. And a lot of it in New York City, as everybody knows, has been concentrated in the delivery worker community. There's, perhaps greater urgency now because of the rash of fires that have happened and the city council hearing at the beginning of the week. And also, the possibility that there could be a bit of a backlash that, for example, my building just completely banned micromobility from all apartments. And I think other buildings are taking similar measures. So I think it's important to sort of, get out in front of that. So like I mentioned, we did this for 2 years. The first phase of this was kind of a general survey of micromobility in New York City. And then the second phase was various challenges to supporting micromobility use. We focused on parking and moving space. And for the DOT folks on the call, you'll probably be familiar with a lot of this. So again, research was focused on New York City. There really is a global context to this. In Europe, they're much further ahead, I believe, with micromobility adoption. And but the US is, I think, quickly catching up. But there are different types of modes that are more popular in different places. So what we did was we went out onto the streets and sort of just took a lot of photos. We did counts, which I'll get to later, just to kind of document what's out there in this city. So again, e-bikes, e-scooters, electric cargo bikes, low-speed electric mopeds, And the standing modes we looked at were e-skateboards, segways, electric unicycles, hoverboards, and even electric roller skates. I think I've seen one person on those. And this kind of lays it out. So I took some of these photos, but some of them are kind of, a lot of these modes go really, really fast. So you have to be really quick and pull out your phone, and then all of a sudden it's gone, especially the electric unicycles. So you see the electric skateboard, which I think is probably straightforward to most people. The segways on the upper right corner, there's kind of like a new generation of segways out now, which are, you know, nicer, more agile than the sort of old kind of dorky segways where you kind of stand up holding the thing and you're, 10 feet high and everything. Then electric unicycles, a lot of people have probably seen these. They go really fast. And some people wear like full body armor while they're using them. Hoverboards, which are, I think, a bit more of like a kind of like a toy now. I don't think they're really used as much for mobility. And they came out much earlier than the other modes, and they go, fairly slow. And then of course the one wheels, which are kind of like a skateboard, but allow you to ride it a bit more like a snowboard and be kind of more agile and get your body into it. So this is the general classification scheme that we laid out. It may have slight differences from what DOT has looked at, and that's fine because we're just, it's more of like a conversation I think we're trying to have. So the three classes of e-bikes are listed on the top with their general top speeds. There are various questions surrounding how they should be regulated. Then you have your e-scooters. There's kind of a range of speeds for these. Some of them actually go really fast. I've seen some that can go up to 65 miles an hour. But generally the range I think is 15 to 25 miles per hour. And then standing modes without handlebars, again, 10 to 25 miles per hour. You're seeing, unicycles go perhaps a little faster than that. The cargo bikes or the cargo bikes with an attachment. There are a lot of different designs to these things, especially looking, say, somewhere like Denmark. People have all different types of cargo bikes, and some of them are just e-bikes with an attachment on the end, which is obviously what the Whole Foods, the city's cargo bike pilot is using. And then of course the mopeds. We kind of defined mopeds as electric micromobility if they're electrified and they have a top speed of 30 miles per hour. So that's, kind of difficult to sort out what's legal and what's not. But that seems to be kind of a good point to divide it. The one issue with mopeds is that they do have a body. So that can potentially, protect the user a bit more, but it's heavier and bigger. So it's potentially more of a threat, safety threat to pedestrians. So getting to the counts, we did our counts in the fall of 2021. And this is the count sheet, sample count sheet, pretty simple. We basically wanted to sort of sort out the micromobility devices from the manual bikes. So we have manual bikes, e-bikes, e-scooters, and then the other category, which corresponds to the table that I just showed. And we went out for an hour at a time. So we separated the counts into 15-minute increments. And getting to it. So the counts, the big number here is that the counts revealed that 39% of conveyances, that's kind of the word I came up with to describe all of these mobility devices, including bikes. So 39% of those counted as bikes were in fact micromobility devices. So to break this down, what our methodology was we went to 13 of the 15 DOT automated count locations. And we chose this largely because it seemed to us that DOT is, really spotlighting the automated count locations, and they seem to have fairly reliable numbers, and there's a bit of a trend. So we went to these locations. We picked 3 times of day, morning peak, lunch hour, and evening peak. And we manually counted. And this is kind of difficult. I know the city is shifting toward doing more and more automated counting, but in our internal discussions and after going out there, we found that it doesn't seem like there is really a way to do it in an automated way at this point. Any kind of computer vision device, I think it would be very difficult to pick up some of the nuances and how to identify what's a micromobility device versus a regular bike, or even a person for that matter. And of course, I can't remember what it's called, but there's a device that's in the pavement at the count locations that the bikes go across to trigger the count. And I don't think that device would potentially be able to pick up the difference between a manual bike and an e-bike, for example. So in any case, you can see the different locations listed down here at the bottom. They range from Amsterdam Avenue and 86th Street, which had a 65% micromobility rate. So that's 65% micromobility, 35% manual bikes, down to Kent Avenue in Brooklyn, which had a 23% rate. And just matching all up, we got the total of 39%. And then you can see the breakdown by specific mode on the bottom right. So the lion's share were e-bikes at 29%, and then you had e-scooters and other micromobility. The one thing that I should cite as a data issue that we didn't fully anticipate before going out there was how to classify mopeds. So there's going to be a bit of inconsistency because I think some people were classifying mopeds as micromobility devices and some people weren't. But this is kind of a methodology that we wanted to take a first stab at and kind of break the ice because we didn't see anybody else doing it. And we don't currently have the personnel to really do this in full force every year, but we're sort of hoping that another agency might be interested in taking the baton and sort of continuing this into the future, because it really is important that we better understand, what devices are out there, how many of them are, a given type of micromobility versus a manual bike. So I'll leave it at there. And if you have any questions, I guess in the discussion afterwards.
Great, thanks, Connor. So up next, we're going to talk about micromobility in the Bronx, novel device quantification and assessment of injury burdens. Angelo Masha, DO, is a New York native trained in emergency medicine at SBH St. Barnabas, currently in emergency medicine attending at SBH and Westchester Medical Center. Also serves as the first clinical quality and safety fellow at SBH with a strong interest in quality improvement and patient safety. And then we also have Eric Marketan, PA, EMT, PCC. Bronx native, coordinating injury prevention programs at SBH St. Barnabas Hospital and teaching resuscitation medicine at the American Heart Association Training Center coordinator, retired 25-year NYC paramedic and first responder, and was also a policy analyst under the comptroller Harrison Golden. All right, so without further ado, yeah, go ahead.
Thanks. I'm going to go ahead and share real quick. Okay, thank you so much for the introduction. So today we're going to talk about what we're doing at SBH in the Bronx, looking at micromobility incidents, accidents, and presentations to the emergency department. I have, as you know, here with me today, Eric, to help me do some of our presentation. So what we're going to be talking about today is introducing our team, looking at the process that we have undertaken at SPH on an effort to quantify and analyze these presentations to the emergency department in hopes of better informing the policy you're all hearing about today from these other various presentations. An overview of our initial data pool back in 2021, some of the highlights of that data, the variables we're collecting, and some of the next steps we're looking forward to. So first thing, so you got kind of a tidbit of who I am. I'm the coordinator at SPH for this project. And then here you can see listed my team, essentially some various EM docs and some trauma people from SPH that are interested in the same parameters that we've been doing for the past 2 years. We started this in 2021. I'm going to pass over to Eric to talk about our interfacility multi-center collaborators. Thank you, Eric.
Sure. Good morning, everyone. To sort of put this into perspective citywide, we are one of a number of adult and pediatric trauma centers, all of whom have injury prevention coordinators that do the work that I do. And we've become quite a tight-knit, collaborative group over the last 4 or 5 years, specific to how we help guide our hospitals through the trauma center verification process. So through the RTAC, the Regional Trauma Advisory Committee, and the greater statewide STAC, the State Trauma Advisory Committee, where we are all represented. And then on a policy arm, where we can be a little more granular in lobbying, that's the American Trauma Society, the New York State Division. We have all expressed an interest in collaborating together for like a multi-center collaborative specific to micromobile. So these are some of the early centers that have committed to joining, and we're just very happy to have a really great group of folks that are all multi-center and collaborative. Next slide. So the next map, and this is something that came to us from the FDNY analytic folks. This is a Bronx map of the 3 trauma centers in the Bronx, SBH, Jacoby, and Lincoln. And you can see in red, this is essentially our catchment geography. If you're a paramedic or EMT basic unit in the Bronx with a trauma patient, and you are using the computer-aided dispatch system to provide you with a recommended adult trauma center, this geography would be sort of where we would become first recommended. Crews do have some variability and flexibility due to traffic patterns and sort of prevailing conditions and burdens on other trauma centers when there's multiple patients, but essentially this shows and demonstrates that there's really a nice even distribution of trauma centers in the Bronx. I think we're probably the most evenly distributed and covered borough. So you have Jacoby to our east, and then you have Lincoln to our south. But you can also see how we cover a little bit of Upper Manhattan. We tend to get those Upper Manhattan trauma patients at night when the units have confidence that they can cross over into the Bronx without the hindrance of traffic. Generally during the days and evenings, they tend to go south into the NYP Presbyterian Center, just a little bit to the south of that red zone. Next slide. So this is our template. I sort of had the genesis of this came from sort of myself being an aviation enthusiast, and I was a model maker when I was younger. And I recalled that there were flashcards, which were basically silhouettes of airplanes that were used by fighter pilots to quickly identify friend and foe. They were also used by the anti-aircraft gunners as well, so they wouldn't shoot down their own folks. And out of that, I figured that we could probably develop some type of silhouette representation of the various micromobile devices, which could, in a clinical setting, be shown to patients, family members, EMS, other first responders to drill down and have some sort of granularity with respect to the actual device. So this is the template as it is currently, the iteration in our trauma bay and in our ED. And the devices then have a corresponding code, which then is built into our current EMR with a dropdown, so that you have a micromobile yes, no, and if it's a yes, then those codes drop down, and a resident or other clinician can easily check off what that device is. So that's sort of where we're at, specific to what the template is and how easy it is to be used clinically. Next slide.
I'm just going to hop in real quick, Eric, on this.
Yeah, please. Yep.
So back in 2021, we've noticed, as in the clinical setting in the emergency department, a pretty sharp uptick in these presentations. And that's what kind of first piqued our curiosity. And that kind of corresponded with the rideshare rollouts in the Bronx. And we've noticed a very large proportion of patients presenting secondary to injury related to their use. Digging a little deeper, obviously every hospital has a trauma registry from which we can pull data and look at presentations. However, that data is slightly limited in that it only captures the sickest of the sick. And anecdotally, we were seeing a lot more patients that are being captured from our trauma registry. So there's a lot more presenting that were being captured. So that's what led to the entire genesis of this project. We wanted to look at and quantify the type of injuries that were presenting to the ED at SBH as a result of these microtransit devices being used on our streets. And we wanted to catch all comers. We didn't want to catch the sickest ones. We wanted to catch every single person presenting. So that brings us to our first iteration of data. So this is a short, like 3 or 4 month run in 2021 around the late mid to late summer through the early fall of 2021. So essentially what we did was about 200 presentations that we captured through this data set. And the process was essentially all comers to the ED as a result of injury related to this, whether they were the operator, a passenger, a pedestrian, would be identified by the clinician taking care of the patient. In our electronic medical record that we actually hard-coded in the template you saw before with the various device codes, we'd actually show this template to the patient, to the EMTs, to see if we can capture the type of device. And then through there, after a several month period of data collection and getting these codes through the clinicians, we were able to abstract some data that you're seeing here based on that June to 2021 to August 2021 period of about 200 patients. So we learned some pretty interesting things. Young adults, males were the average rider age, about 31 to 32 years of age. You can see there 87% are male. A large proportion of them were unhelmeted. Very large proportion were the operators. I can see there 88% were operators. Several were passengers. Several were pedestrians. Something I threw in here that was a little bit interesting. We were expecting to see like joyriding, late night weekends as a high frequency of presentation. We actually found the median day and time to be around lunchtime, around 4 o'clock during the week, which led us to believe that maybe this is people delivering food on rideshare delivery platforms. So that was a little bit interesting. I wanted to share with you all. And essentially what we did is we went through every chart that was presented and we calculated an injury severity score for every chart, and we broke that down as you see here. So basically, were they mild presentation, moderate presentations, or severe presentations? And then in the actual paper that we wrote up, that's not here unfortunately, is we actually broke that out by device type. So we're able to see the various types of injuries in correspondence to the device they were riding. So you can see some diagnosis there, the most common diagnoses that were presented as a result of these accidents, sprains, abrasions, lacerations, some fractures. And what we saw was that a large proportion of these were essentially walking well. They had minor injuries, some sprains, some strains that didn't require a trauma activation or admission to the hospital. And these were all being missed by our trauma registry. And that was our driving force of wanting to capture these. Just going a little bit deeper into the first iteration, into the variables that we're capturing. So essentially what we're looking at is basic demographics of the patient, their age, their gender, their ethnicity, what time they're coming, how they're triaged, how they're brought to the emergency department, their diagnosis codes that you saw on the previous slide, and how they were involved in the accident, whether they're operators, passengers, pedestrians. And again, this is all looking at, number one, trying to quantify the types of injuries, and number two, hopefully looking to expand this to outside sites to better inform public policy that you're all working on in your various departments. I'm going to pass over to Eric to talk about our collaboration with the Vision Zero initiative and the helmet initiative that he's been working on too.
All right, so one of our initiatives was to distribute helmets both in the community and then also in the ED. So what we instituted was a small par level of helmets in our PPE room, which is very easy to access from the charge nurse, and a log where a patient label could quickly be put into the log. The helmet could be provided with some fitting instructions, and essentially you have someone sort of leaving the ED with a helmet, even if their presentation wasn't a micromobile crash. Some sort of impediments that we encountered. I mean, we are a busy trauma center. We're a very busy service. Residents and clinical staff are challenged with clinical care, and so the level of distribution sort of wasn't where we were expecting. So there was a little bit of a fallout for us, and we decided to sort of pivot a little bit more to our clinics, and that's where our family dental and our pediatric ambulatory clinics are also becoming great settings for helmet distribution. Where Vision Zero has been helpful is the helmets, and we received 150 helmets from them in 2021, and we just recently received a little over 300 helmets as part of the Vision Zero initiative. So truly grateful to that collaboration with Vision Zero. And as we know, roughly 85% of our injured are not helmet wearers. We found impediments. I recently gave a helmet to one of the young men that delivers food to me, and was very pleased by that, only then to find a few deliveries later he wasn't wearing the helmet. So we had a little discussion about that, and really what it came down to is what I think a lot of folks, they say it's just not something that he's comfortable, so it's not part of his kit, and that's going to be a sort of a change both in a community norm and probably in an individual norm. But we are pushing the helmets out. All of our trauma centers are, and I think it's a great initiative with Vision Zero.
2.5 minutes left.
Sure. I was just going to go over the current project status and what we're doing currently in the year of 2022. So essentially, we began extracting our data for a longer time span in 2022. We about 300 to 400 presentations in the ED. We're in the process of crunching right now. We've presented this at various other meetings that Eric has mentioned previously with some strong interest at multi-center sites. We're looking to expand this data collection process to various other clinical sites to expand on the veracity of our data collection. So essentially, this is just a snapshot of what we have so far. So again, around 300 to 400 presentations related to micromobile use. Majority remains to be moped riders. I believe that fall into this unlicensed, unregistered category. We've had 4 related fatalities in 2022 alone, including the death of, unfortunately, a 4-year-old child that was riding along on a scooter. In October 2022, the most recent data we have, we've had 13 high acuity presentations related to transit, all coming transit, not just microtransit. 7 were microtransit related, 6 pedestrian struck. Just in the interest of time, I'm going to go through this. So again, this is just us looking for collaboration through various sites, looking for multi-center partners to work with us to expand our data collection. And a plea to all of you here, I am not a statistician. I had ran all of the stats myself on the first paper. I think there can be a lot more a lot more information to be gleaned from somebody that is trained and fully functional in stats. So if you have any interest in working with us, we are more than welcome to have you. This is my contact and Eric's contact. Please feel free to reach out to us if you are interested and like to help.
All right. Thanks so much to Angelo and Eric for that. Yeah, folks can put their questions into the chat, and I can call on them as we go. There was a question from a while back for Anne Marie. This was I think question was any concerns that riders do not follow traffic rules? Are they running red lights, traveling the wrong way on the road, riding on the sidewalk in terms of, e-mobility?
Yes, certainly a concern. And I think, as Eric and Angelo mentioned, that, the helmet giveaways have been very successful. I know we go to a lot of open street events and give away helmets. I mean, that's just one part of it, but the safety education piece is a big part of it as well. Which is led by Kim Wiley Schwartz over here at DOT, and she does a lot of outreach and education to the bike community. I don't know all the details. Julia might have a little more if she's on here, knowledge about how we do that, but certainly education is a big piece of this puzzle that we all need to work on for sure.
Great, thanks, Anne Marie. So we had a question from Carl Sundstrom. This is for Eric and Angelo. Question about, were head injuries captured in this injury data? And I was thinking about this as well, just in terms of the helmet initiative. I wonder what what percentage we feel like that would be addressing.
Yes, they were captured. I don't have the specific paper in front of me, but we do have closed and open TBI data. If I recall, based on the entire data set, it was a smaller proportion. Moving forward in this larger capture of 2022, we're going to look into that with some more granularity to see if we can further specify the types of head injuries that were sustained.
Looks like there's a question from Gary Hecker for Anne Marie. You can just take yourself off mute, Gary.
Hi, Amory. I have two questions. First off, the fatality data you say you're getting from NYPD. So is that limited to death on scene or death immediately in the ER? And are you missing death down the road when the person's in the ICU or in the hospital? And should you better get that data from the medical examiner versus the police department, because you'll capture other deaths? And then my second question is, as everybody said, it's hard to track down which device is being used, the person's role and everything else. It's really hard for us at Jacoby to differentiate, was it part of the e-scooter share program or personally owned e-scooter? But the e-scooter program between phase 1 and phase 2, I'm looking at the report that just came out a couple of days ago from the DOT, over close to 6,000 scooters were put on the road in the Bronx. Can you honestly say with certainty that there were no fatalities and no major injuries, considering the number of scooters that you guys put on the road? I mean, we've had since June of 2021, 7 people die. We've had 260 some odd patients with a total of 357 individual injuries, some of them serious like skull fractures and brain injuries, major bone fractures. Can you honestly say in your report that none of those were attributed to the e-scooter system?
Okay, I'll answer the first one first, and then I might need help with the second one. But so to answer your first question, yes, we do get we reconcile with NYPD pretty much daily. So if an e-mobility is involved, injury happens, we do get the information. It gets reconciled down the road if there is a death. So we include that in our stats. So that's definite. For your second question about the scooter share. So for the scooter share, positively, we know there were 0 fatalities for the scooter share. I'm sure there's a lot of people using these types of scooters out there on their own, but they're not part of this the scooter share program. And as far as the injury data for the shared scooters, I'm not sure, Rob, I know you're on those calls with
Yeah, we do
team.
we do kind of these bi-weekly calls with all the scooter share companies. They show us like their injuries, their reported injuries for the week. And there are some severe injuries, but the vast majority that are happening are minor. But from time to time, there's severe injuries. But yeah, I can definitely confirm that fatality number, because we're working with the vendors, but also working with the police as well, because they're looking out for that. And just to reiterate or give more detail on Anne Marie's first answer. We actually are an extreme outlier in terms of tracking traffic fatalities. We have no time limit on if someone dies from a traffic related injury, even if it's 20 years later, if the medical examiner says that was cause of death, we actually change our numbers from 20 years back.
Yeah,
So
that's true.
almost all municipalities have a 30-day rule. So we're yeah, we definitely lean in the other direction.
Rob, quick question for Anne Marie. This is Eric here. Specific to your graph regarding the fatality data, I noticed that you had motorcycle operators, but do you also collect for motorcycle passengers? I speak to that because we did have a motorcycle passenger fatality in the month of May of this year.
Yeah, yes, we track all of that. We track motorcycles or I don't know why it says motorcycle on that slide, but motorcycles are in a completely different category, an official motorcycle. And we of course track the deaths of the driver as well as passengers.
Yeah, it's a very, very tiny percentage, like something like 95% of the motorcycle fatalities are, one person on the bike. But
Right.
yeah, but it definitely shows up in our numbers.
One impediment in our data collection real quick is sometimes folks are masking the mechanism of injury specific to the legality of their device. So they may not be reliable historians specific to what they were writing, and that's why some of our multi-center colleagues we're looking at EMS to better capture the true what's happening on the street from what we're being told in the ED.
All right, I think we're just about out of time. I saw the countdown clock pop up. Yeah, just wanted to thank everybody for participating, and Eric and Angela, I want to follow up with you afterwards about the number of fatalities you've seen there, and make sure it lines up with our numbers, because that's I think you said 4, but Gary also said even higher number. So I'm going to take a look at that, make sure we're getting everything.
Sure.